Video today on 4 types of adenomyosis that we see in Chinese clinical practice. We see the same 4 types in the UK, but one much less common than one might see in Shanghai. Adenomyosis is a close cousin of endometriosis, and it describes a situation where the lining of the womb grows into the muscle of the womb. It can be painful, it can be painless. And you'll see as we classify these different types in what we call the Shanghai system of adenomyosis, how that pain is relevant. So this work's been done in Shanghai Jiatong University under the leadership of Professor Huang Hefeng in her hospital at Shanghai. This is the ward block for 16,000 deliveries a year. This is the outpatients department and the service unit here. All of it sits on the underground station at Shanghai. And with respect to adenomyosis, it was first described by this man, Karl von Rokitansky, in Vienna in 1860. Rokitansky was the first man to really use a good microscope in a consistent fashion, and he really revolutionized clinical pathology as a result of this new innovation. In terms of adenomyosis and its extensive study and classification, it was this man, Thomas Cullen, from, in fact, it was McGill University, I think, where Cullen did his work. He wrote books on both adenomyosis in 1908 and myoma, fibroids, in 1909. And this here you can see is a description, or it's an example of a pathological specimen showing adenomyosis. And this is the lining of the womb. It's much more bulky, and it's invaded into the muscle of the womb like this. This one is only 260 grams in weight, but we can see much bigger specimens weighing over a kilogram in some circumstances. These are the 4 types we've shown. It's going to show you them radiologically to begin with. First of all, there's this very large uterus, which is there's diffuse adenomyosis all the way through its diameter. And this is entirely painless. And that will be easily explained in due course. This is more common in China than in the UK. This is the common variant in the UK. This is a painful pattern of adenomyosis where you can see this thickening of the lining of the womb here. It extends into the myometrium and often associated with an enlarged cervix. Type 3, you can see on the posterior wall here a myoma. This one's a leiomyoma, or a tumor of the smooth muscle. The other pattern that we see is an adenomyoma. Both of these are focal and painless. And finally, we've got a dustbin of all the other kinds of adenomyosis, which are congenital or pedunculated. And there's different patterns of polyps that arise that can contribute in this set of circumstances. So what I'd like to do is just walk through each one, showing you the how frequent they are. The type 1 we found in 100 consecutive specimens, 3 observers. We looked at the MRI pictures. We found 11 out of 100 were the diffuse symmetric painless type 1s. 23 were asymmetrical painful adenomyosis. 50 were the adenomyoma or leiomyoma, and a combination of types 2 and types 3 accounted for 15. So type 2 and type 3, the common forms. In China, we see plenty of this. 10% would be in this diffuse symmetric painless adenomyosis, and then a very small number, one in this series, that were involved in these other patterns, unusual patterns. This is the type 1, and what I'm going to show you here is the clinical, radiological, laparoscopic, and histological features of each syndrome. So type 1, diffuse painless adenomyosis, and what you can see here is this diffuse thickening of the endometrium as it invades into the uterus. There are no uterosacral ligaments. That's uniformly the case. All these women have had procedures to evacuate their uterus, either for miscarriage or abortion. and often they've been treated with both medical and surgical procedures. There are no nerves at the lining, at the junction between the endometrium and the myometrium. Usually there's a large endometrial myometrial nerve plexus here. And in the fallopian tubes should look like this with plenty of rugae, but these fallopian tubes in these women are like drain pipes. So the key features in my mind are that there's this diffuse, painless, symmetrical enlargement. There are no uterosacral ligaments, and they're the bits that conduct the nerves into the uterus to supply both the uterus and fallopian tubes. And there are absolutely no nerves at any level of the uterus or fallopian tubes in this series of women that we looked at in Wenzhou. In type 2, this is a more familiar pattern for the UK audience. Here we see this irregular enlargement, thickening of the lining of the womb as it runs into the muscle of the womb. The key here is that there is scarring of the uterosacral ligaments as they run into the back of the uterus. And this is a consistent feature. But there is continuity. There's no breakage. There's no loss of ligaments. There's just injury. And because that injury is in continuity, the nerves regrow into the back of the uterus and look like this. These are injured, painful, abnormal nerves which express all sorts of different pain and stretch receptors. And the blood supply is also impaired to some extent with the narrowing of the arterioles in the same ligaments. As I said, the cervix tends to be a little enlarged compared to other patterns of adenomyosis, and you can see it routinely, these injuries routinely on MRI scanning. So that's type 2. This is type 3, adenomyoma or leiomyoma, both are the same pathology. And what we see in this circumstance is a focal injury to the uterosacral ligaments, not an extensive injury like the ones we've seen previously in the previous 2 types, but just a light injury. And that will become clear in a minute. That means there's no nerves. That leads to no nerves in the myoma itself, and no nerves in the nerve bundles just below that, within 2 low power fields of the myoma. Associated with that, there is thickening of the arterioles, a leash of arterioles, which classically is within 2 low power fields as well. And you see these thick arteriolar walls which denote prior denervation. So these are the key features. There's no nerves in the tumor, focal injuries to the uterosacral ligaments, and loss of nerves in nerve bundles associated with thickened arterioles. Now, that's all very interesting, but they actually concur with different procedures for evacuation of the uterus. And I'm not saying that these are the only sources of these injuries, but if we look at normal uterosacral ligaments here, type 1, the diffuse painless, are associated with big injuries to the uterosacral ligaments associated with excessive traction to the cervix during evacuation procedures, usually in second trimester pregnancies at 16 to 18 weeks gestation. The type 2 is the typical 10 to 12 week gestational termination of pregnancy, where some traction may be used and cause some degree of avulsion of the uterosacral ligaments that does not destroy their continuity with the uterus. And finally, there's a third pattern, which is in China, they often use infiltration of the uterosacral ligaments to do the suction evacuations for uteri of less than 9 weeks size. So there's all 3 patterns of injury reflect different patterns of evacuation of the uterus at miscarriage or at termination of pregnancy. And these procedures are extremely common in China. And but they are not the only mechanism for injury to these nerves. So in summary, 4 types of, or 4 different patterns of adenomyosis, and they're the consequences of injuries to uterine nerves at different anatomical sites with markedly different clinical consequences. They have distinctive clinical, laparoscopic, radiological, and histological features. And the injuries to the uterine nerves, as we say, have different pathological consequences depending on the site. So what we have is further studies are clearly necessary to confirm these observations, but it's interesting that all three major gynecological pathologies of endometriosis, adenomyosis, and fibroids are all associated with injuries to uterine nerves of one description or another. We think that's compelling and a consistent observation, and travels towards causation without actually proving it. Clearly, there's a significant job to do in preventing these injuries. So I hope that's something novel, a little new, something to reflect upon before we next meet again. Thank you very much for watching, and we look forward to seeing you next time.